Good evening. It's a pleasure to welcome you to today's ESDS webinar with the title A Peek into the Crystal Glass, Important Ongoing Trials in Thoracic Surgery. It's a great pleasure and honor for me that we have today three speakers who really, I think, need no further introduction in this forum, who are really prominent leaders in their field, and each of them has conducted several important ongoing trials, and all of them are involved in an enormous amount of clinical and translational activity. And so as the first speaker, we'll have Isabelle Opitz from Zurich, who will give an introduction into the new ESDS test platform, and then talk about the topic of lung volume reduction surgery. The second speaker will be Eric Lim from Brompton, who's going to talk about lung cancer trials, and then we will have Shaf Keshavjee from Toronto, who will talk about trials in lung transplantation. As always, please ask the questions via the chat tool or the Q&A function, and we will have a discussion at the end of the speeches. So, Isabelle, the stage is yours.
Thank you, Clemens, for the kind introduction. It's a real pleasure for me to speak here along this amazing faculty today. And the title of my talk is A Peek into Crystal Glasses, Important Ongoing Trials in Emphysema Thoracic Surgery. These are my disclosures. First of all, it is an honor and pleasure for me to present to the community today one more time our test platform. It's the Thoracic European Surgical Trial Platform, a clinical trial platform that was founded in 2023. And this platform has been created because we wanted, as a society, enhance clinical trial activity within thoracic surgery in Europe and our ESTS community. Our aim is to support both academic and industry-sponsored clinical trial, but also other research projects such as clinical databases by connecting sponsors with our member institutions and trial sites. We also want to enhance quality assurance in surgical trials and increase and promote the accrual of patients into clinical trials. And we believe that this platform will further motivate also our members to conduct clinical trials in high quality within the society. So this is our steering committee, which consists of members of our board, of course, because it's important to have them aligned, and other representatives of the society with relevant experience in clinical trial conduct. We're very happy and proud that as of today, we have 31 sites within the test community, which are spread all over Europe. So far, we are supporting 4 investigator-initiated clinical trials. We have one industry-sponsored trial and one real-world international registry, which I will show to you in a minute. So the industry-sponsored trial is from AstraZeneca, the TROP12 trial. I will not go too much into detail, but it is a trial where ADCs are tested in high-risk feature stage 1 non-small cell lung cancer patients. These are the selected test sites who will participate into this trial, and the opening of these different sites is currently ongoing within Europe. Furthermore, I would like to present to you the test real-world databases that are ongoing. Why do we need real-world databases? We all know clinical trials are highly controlled and somehow artificial experiments, whereas in contrast to this, real-world data refers to data derived from clinical or routine clinical practice and are important comparators. For this, our ESTS database, which is currently the director of the database, Raoul Mbun, is a very valuable source for this. Currently, the first real-world data registry that is ongoing is a joint project together with TTOC, which is the Thoracic Surgery Oncology Group from our sister society AATS. And this is a multi-institutional prospective registry trial where we collect data on patients that undergo planned pulmonary segmentectomy for primary lung cancer. several perioperative data will be collected from the patient medical records, and also patient-reported outcomes will be prospectively assessed within the trial. So this is TSOC, as I mentioned before, from our sister society, equally having 30 sites stretched across North America with a very successful track record of performing clinical trials. Dr. Jones, who is the PI of this project, and me have found together for this TEST TSOC first collaborative project, and we're really looking forward to this joint collaboration. These are the test sites that are involved in the TSOC test pulmonary segmentectomy registry. And the objective, or let's just focus on the primary objective, is to determine the 3 and 5 year disease-free survival among patients undergoing segmentectomy for stage 1 non-small cell lung cancer. So I think my main message for all participants today is, if you're not yet a site of test and you have interest in being part of clinical trials, being either investigator-initiated or in an industry-sponsored trial, please reach out to our coordinator, which is Jean-Marc Hoffmann, and also to me, and we can get you connected to our test site. And with this, I would like to get over to the second part of my talk, which is current studies going on in the context of lung volume reduction. I will just briefly give a background information and introduction about the disease, just to set the scene and to let you know that this COPD and emphysema continues to be a very relevant healthcare problem and currently continues to be the third cause of death worldwide, why it is important to further continue our research efforts in this disease. It has been proven in various trials that lung volume reduction surgery has a clear benefit for emphysema patients. And in the next and following, I would like to show you trials that have been done and are currently ongoing within the field. I have to temper down already your enthusiasm that currently there are not many trials going on. And I also think we cannot speak about LVRS trials without mentioning the NET trial, which was already 14 years ago, a randomized controlled trial comparing lung volume reduction surgery with medical therapy. It was a large North American multi-center trial, and it provided extensive data not only on the clinical expression, but also the treatment of emphysema. Patient selection was extremely strict, highly selected, and only severe airflow obstruction, hyperinflation, bilateral type of emphysema, and no significant comorbidity type of patients were allowed. In contrast to this, don't read the details, but just to show you, there was a big and a large list of exclusion criteria, one of them being even moderate pulmonary hypertension patients were excluded. When we look at the primary outcome, which was survival, there was no overall survival benefit when we looked at all patients. However, in selected subgroups, such as the high-risk patient subgroup, the survival benefit was there. Looking at the LVRS outcomes, the functional improvement, patients had better exercise capacity up to 5 years, and the best responders were patients with upper lobe predominant emphysema type. However, there was a high short-term mortality for the surgical group, 7.9% in comparison to 1.3%, and obviously morbidity was also higher after surgery. For the surgical technique, there were similar outcomes for median sternotomy. However, minimal invasive surgery had a shorter hospital stay and lower costs. Cost effectiveness was another outcome parameter, and surgery was expensive initially, but became more cost effective over time. So in conclusion, this was an enormous effort for doing such a large randomized controlled trial in North America, and this trial provided indeed critical insights into the disease management. However, despite these proven benefits in particular subgroups of patient, lung volume reduction surgery remained largely underused, in particular in North America, but also in the beginning in Europe, because of the misinterpretation of the risk and limited access, and also the complexity of evaluation. I think since then, we and also many other groups have shown that there might be a benefit of lung volume reduction surgery if patients are included beyond the net selection criteria. And my colleague Didier Schneider just presented at AATS our experience over all the 20 past years, where we could have in more than 700 patients significant postoperative improvement with a mortality less than 1%. As I mentioned, more than 700 patients with relevant FEV1 6-minute walking test improvement and equally hyperinflation improvement. Coming to another very important trial, which has been conducted in the UK, assessing lung volume reduction surgery versus endobronchial valves, the first randomized controlled trial in that field, also a very big effort. And it was a single blinded superiority trial. And the primary outcome was comparing at 1 year the iBode score. Finally, 88 patients were randomized and assessed at this 12-month follow-up time point. And both groups improved to a similar extent. And also, not only the overall iBode composite score, but none of the individual components were different between the two treatment groups. Also, in hyperinflation, there was a similar reduction in gas trapping in the LVRS and also in the bronchial valve group. Survival did not differ between both treatment groups, and only the CAT score showed a significant improvement favoring lung volume reduction surgery, which is why the authors from this trial conclude that in patients who are considered to be suitable for both treatments, that there was no evidence that outcomes following LVRS were superior to bronchoscopic lung volume reduction. However, there are a few discussion points that I would like to draw to your attention. Number one, again, big effort, and has to be congratulated the UK group for the first randomized controlled trial comparing both in a superiority design. However, there was a relevant number of patients that was lost to follow up or crossing over between the treatments group, more in the bronchoscopic group, and eventually becoming more over time. The deaths in each arm were they treatment-related, unclear, and finally, the secondary outcomes, CAT score and EQ-5D, were relevantly better in lung volume reduction. Unfortunately, there wasn't really much information about the surgical approach, which is definitely missing. So coming to the current situation, when you do a search on clinicaltrial.gov, you will see when you look for emphysema studies, it's quite sobering. The currently recruiting studies, randomized controlled trials, are mainly for new techniques of the endobronchial way, such as, for example, the thermal liquid ablation, the so-called REDUCE EU trial that you can see here in the third line. It's about ablation technique for endobronchial application, which is an industry-sponsored trial. All the other trials that are ongoing are mainly trials assessing if patients with collateral ventilation can be, by some technique, converted to be eligible for bronchial valves. So, for example, here, first trial that you can see that is currently ongoing, which is sponsored by Pulmonx, is to evaluate the area seal system to convert collateral ventilation status for patients with emphysema. Another trial that you can see here that is also from Pulmonx sponsored, combined valve systems for interlobar fissure completion. Then there is another trial ongoing where interlobar fissure completion for failed bronchoscopic lung volume reduction, so as a second procedure, and also the last trial, which is an endobronchial trial evaluation of, again, thermoablation. So the only currently ongoing and recruiting trial for surgery, again, is run in Zurich, which is the so-called SINCERE trial. It is, of course, a multi-center trial where we have participating sites not only in Switzerland, where it's overall 3 centers, but also Leuven in Belgium is participating, Copenhagen, Denmark, and Vienna in Austria. And currently, Rouen in France is embarking on this trial. So it is a superiority design where we assess lung volume reduction surgery in a randomized controlled fashion versus bronchoscopic lung volume reduction. We allow bilateral or unilateral lung volume reduction surgery according to local investigators' choice. The sample size population is 140 patients, and the primary endpoint is FEV1 at 6-month follow-up, and the secondary endpoints FEV1 at 3 and 12 months. Of course, other pulmonary function tests, palrometers, as well as 6-minute walking tests, and a whole series of quality of life assessments. Adverse events are monitored at 3, 6, and 12 months, and of course, 30, 90-day mortality and overall survival at a 12 months follow-up are assessed in secondary endpoints. So this is the workflow and study assessments where you can see patients are enrolled after fulfilling all inclusion criteria and then undergo bronchoscopy, including Chartis measurements. If they are eligible for both procedures, they will be randomized in valves and LVRS according to the study protocol. In parallel, we are having an observational cohort for patients who did not qualify for enrollment. That's a little bit like a TWIC design, where we have patients within cohorts that are in parallel assessed to have this real-world data to be a comparator later in the analysis. Currently, 54 patients are enrolled in the randomized protocol, and many more patients are in the cohort study. So in summary, I would like to say that many years after NET, we can conclude that active treatment for emphysema, both valves and surgery, improve quality of life, dyspnea, and also survival for emphysema patients. And we still hope for broader translation into clinical practice. The choice of procedure, I think, depends on many aspects, and we're still hoping for more inclusion of patients into clinical trial to further elucidate that question. And if you're interested to participate in our ongoing Sincere trial, please reach out and contact us for participation. And with this, I would like to thank you for your attention, and I look forward to your questions afterwards.
Thank you, Isabelle, for this excellent overview, and we will directly move on to Eric's presentation on lung cancer. Eric, you are still on mute.
Thank you very much. Pleased to be here today. Thank you for the kind invitation to speak on this event. Here are some of my disclosures. So the lung cancer space is phenomenally huge. It's so big, it's impossible to cover every single study. So I've kind of grouped it all into certain themes so that we can discuss what's happening today. We're going to start with resectable lung cancer with surgery as part of multimodality management. Now, as you know, with increasing lung cancer screening, it's predicted that most of the lung cancers in the next 5 to 10 years will be detected at an early stage. And as a result, every single pharma company is jumping on the bandwagon, getting their successful drugs in the stage 4 setting for which it's efficacious, and now trying to assess it in the early stage setting. So as always, there are a few themes. The first is immunotherapy, and I think it's more or less done and dusted. You've got so many big trials with Keynote 671, you've got Checkmate 77T, so on and so forth. So a residual smattering of a few more trials left. You've got Anvil testing adjuvant nivolumab after surgery and chemotherapy. You've got the Alchemist trial testing the addition of pembrolizumab to the usual chemotherapy. And then you've got Empower 30 looking at neoadjuvant atezolizumab plus chemotherapy followed by adjuvant atezolizumab. I doubt that any of these trials will actually move the needle, and I think that perioperative immunotherapy really is currently the leading regimen to date. Then for oncogene-driven cancers, what we have is EGFR. You may know Neoadura has just been, the results have just been released. This year, they assigned 358 patients with EGFR mutated stage 2 to 3B resectable non-small cell lung cancer. And I could have told them the results. In fact, I did tell the company the results before it was released that there'll be no difference. Because what's the difference in the trial design when you give osimertinib for 3 more weeks in one arm, neoadjuvant, compared to adjuvant in the other arm? As you can expect, I think hundreds of millions have been spent on this trial to get 93% event-free survival in the neoadjuvant versus the adjuvant osimertinib arms. Pretty much in this EGFR space, that's what's happening. Then the KRAS space is quite interesting. You've got 2 groups of studies in the KRAS space. You've got the neoadjuvant and the adjuvant. For the neoadjuvant, again, it's interesting why companies want to do neoadjuvant studies. And the answer is because they are hoping to short circuit the process. Where you do a neoadjuvant oncogene-driven trial, it shows great pathologic or major pathologic response, with the idea or hope that you may not have to do a big time adjuvant study. When you have surgery, you get the results of the neoadjuvant treatment. The neoadjuvant treatment is often given in a very short span of time. And so to be able to get any positive signals, usually it's a long stretch. So in KRAS, you've got a few contenders here. You've got sotorasib, and then you've got adagrasib in combination with nivolumab. And then you've got the LCMC4 looking at an umbrella trial screening the neoadjuvant patients or giving them neoadjuvant KRAS and seeing how they progress. I think a much more interesting space is the adjuvant KRAS space. And then you have olomorasib, and also you've got divarasib as well. And these are the 2 current ongoing KRAS adjuvant studies. And with most of the adjuvant studies, for whatever reason, they like to stop it at 3 years. And we're going to see the outcome usually of progression-free survival at the 3-year mark. The results of the oncogene-driven drugs are unlikely to be as hard-hitting as EGFR. EGFR has a hazard ratio of 0.2. So, osimertinib trials have phenomenal results. Let's see what KRAS has to offer. The next big hitting oncogene is the ALK and ROS fusions. Now, these characteristically have phenomenal response rates. You already know about the ALINA trial, which is adjuvant ALK inhibitors. Then you've got another few trials coming on, ensartinib and taletrectinib. Again, the adjuvant trials looking at ALK or ROS positive resected non-small cell lung cancer. Another smaller group is the RET fusions, and we have the recently completed Libretto 432, and we're waiting for the results. Libretto 432 was a sponsored trial by Lilly, and they actually stopped the trial, I suspect due to difficulties in recruitment, with the anticipation that you will get a phenomenal, wonderful hazard ratio. Let's see if that proves to be the case. The next interesting area is going to be antibody drug conjugates. You've got HER2, which is an antibody drug conjugate, and the LCMC4 leader trial is an umbrella trial looking at HER2 ADCs in patients with resectable lung cancer, hopefully directing them to personalized neoadjuvant therapy. But what's also being developed in the background by Boehringer is zongertinib, which has been recently published in the New England Journal in Advanced Disease, and that's going to be evaluated in the adjuvant test setting as well. So this is going to be, I think, quite a big area for which we're going to see quite a lot of movement in. Staying on the topic of antibody drug conjugates, Isabelle has already mentioned tropion-Lung12, which is the use of antibody drug conjugates in early stage 1 adenocarcinoma, who are ctDNA positive or high-risk pathological features. And I think this is going to take 3 to 5 years before the results are out. Last but not least, we've got the adjuvant mRNA cancer vaccines, where you resect the tumor. This is one which is done by MSD, and they're going to develop specific mRNA vaccines to see whether or not they can improve survival in high-risk stage 1 non-small cell lung cancer. It's really interesting for me to see the movement in the stage 1 setting as well. Now, all these studies and examples I've given is great, maybe improve survival for patients, but doesn't really affect us as surgeons. As surgeons, you're going to be told what to do. This works, give it before, during, after, before and after. So the next part of my talk is to explore a bit about changes in decision-making, expanding the pool for surgery. So in the unresectable setting, you've got quite some interesting studies which are just being produced. You've got the MDT Bridge study, where patients with borderline or considered unresectable to receive neoadjuvant durvalumab and chemotherapy. And what's really interesting in this study is that you see the borderline patients who are borderline resectable, 71% resection rate has been achieved. So this is quite an important study showing the impact or interest in pharma as well as academic researchers going into the induction setting, where initially tumors are unresectable, then after initial treatment, phenomenally responsive treatment, to become resectable in the majority. The next trial is LungMate 13, and that was presented at ESMO early on this year. You've got serplulimab, and then patients with initially unresectable stage 3 disease, after receiving serplulimab, went on to receive either, this is super interesting, surgery or radiotherapy, with the results showing phenomenally better survival in patients who receive surgery. And obviously, this is not the randomized component, and you would expect that the patients who receive surgery were maybe better, fitter, earlier stage disease. But once again, showing that we don't always know what the best outcome or treatment regimen is after initial induction treatment, where patients who are initially unresectable then become resectable. And of course, there is the unresectable M1 lung cancer, where surgery is offered as part of multimodality local consolidation treatment. As you know, M1 disease traditionally has been a no-go zone for surgeons. And then the MD Anderson group has presented results of North Star, which is a phase 2 randomized trial of osimertinib in metastatic advanced EGFR mutant non-small cell lung cancer. Patients were randomized to receive osimertinib alone or osimertinib and local consolidation therapy, which includes surgery or radiotherapy for advanced disease. And you see phenomenal results showing that the local consolidation arm resulted in a 34% reduction in progression-free survival. Once again, opening up the possibilities of surgery in advanced metastatic non-small cell lung cancer. We've got similar non-randomized studies looking at brigatinib in ALK rearranged advanced lung cancer. And on the background of this, obviously, is the NRG-LU002 trial, which was conducted by Clemens Aigner, also for local consolidation therapy, which showed no improvement in survival in patients who are all comers receiving local consolidation. This question obviously is also being explored by Isabelle with her group, with the salvage study in Switzerland, hoping to be able to evaluate the role of local consolidation treatment in patients with advanced oligometastatic non-small cell lung cancer. Given the scope of the field and what's been published so far, the results are currently showing that if you offer LCT to all comers, it tends to show minimum to no effect, and the LCT has the main effect really in the oncogene-driven lung cancers, which are EGFR or ALK positive. Last but not least, a super important group, obviously, it's surgical decision-making for resectable lung cancer, and perhaps one or two really important studies here is stablemates, most of the studies comparing surgery and radiotherapy for resectable lung cancer didn't manage to recruit in time, and stablemates, I believe, will be recruiting almost to completion. And once again, phenomenally important study that would likely influence the choice of surgery or radiotherapy. Need to mention about the studies undertaken by Haikuan Chen and his group in China. One of the first most important studies showing a randomized trial to systematic nodal dissection or no nodal dissection in GGO predominant lung cancer. And the results, again, phenomenally surprising, showing that complications were higher in the node dissection arm with no evidence of improved outcomes. In fact, the study was stopped prematurely because of the harm caused by node dissection. And the results revealed that regardless of whether you did node dissection or no dissection at all, there weren't any lymph node metastases in the node dissection arm. So in order to reduce complication rates, the steering committee stopped the study, showing no benefit for lymph node dissection. They have a whole suite of studies being prepared. They first looked at part solid tumors with a consolidation tumor ratio less than 0.05, but they are going on to look at the lymph node dissection strategies for a series of other pathological features, and I think this will influence what we do going forward. So in summary, I would say that for multimodality trials with lung cancer screening, the majority are going to be early stage, and pharma companies are going to be evaluating their advanced products in the setting of unresectable, in the setting of resectable lung cancer in a multimodality fashion. Doesn't really affect us. Indications for surgery really affects us, and the locally advanced, initially unresectable with oncogenic driver mutations in this group to receive induction treatment followed by surgery. And the next is the systemically advanced unresectable lung cancer with oncogenic driver mutations to receive systemic treatment followed by local consolidation. That's going to be super important. And last but not least, the surgical decision-making studies, selection for surgery versus radiotherapy, and the lymph node management protocols. As always, you're not going to be able to interpret the trials unless you have a good grounding in statistics. And so please consider brushing up on this topic. Thank you very much.
Thank you, Eric, for this detailed overview on the various fields of trials in lung cancer. Shaf, we're moving forward to the lung transplant and looking forward to your presentation.
Great. Can you see my slide is full screen?
Not yet.
Sorry, just let me unshare everything. Sorry, I'm having some trouble here again.
At the moment, we can see the PowerPoint open. However, it's not yet full screen.
For some reason. Let me just see if I can get that. Okay, do you have it now?
It's in presentation mode now. So in presenter view.
That's the one. Yep.
Yeah, perfect.
Yeah.
Thanks, Eric. I learned something today. Okay, thank you very much for having me here. Again, I was asked to cover the important ongoing trials in lung transplantation and thoracic surgery. And I have a number of relationships of companies that we spun out related to the research that we do in ex vivo lung and telemonitoring as well, and the industry partners who have helped us along the way. So, in looking into the crystal ball, I broke these down into 6 areas of trials that are ongoing in lung transplantation, lung preservation, access to lung transplantation, donor lung utilization, primary graft dysfunction prevention or treatment, cell-free DNA in primary graft dysfunction and rejection, and chronic lung allograft dysfunction prevention or treatment. So first of all, in lung preservation, Conrad and Marcelo are running the 10 degrees centigrade versus ice preservation randomized control trial. This is a really important trial because it really challenges how we've done transplantation in the last 50 years, and really changing, using the science of how we preserve organs at 10 degrees, being superior to 0 to 8 degrees, whatever other devices or ice do. So it's a multi-center trial, 17 centers all over the world that are participating in this trial. And they're very close to finishing. Of 320 patients, they're now, I think, at 315 randomized patients in this study. So hopefully, again, patients are randomized, the lungs are randomized. If they're not going to ex vivo lung perfusion, they're randomized to standard preservation in an ice cooler or 10-degree preservation on the export 10-degree storage device. So I think hopefully that's been submitted as a late-breaking trial. So in terms of access to lung transplant, we know that this varies a lot around the world. So Megan and I are leading an NIH trial, creating access to transplant for candidates who are high risk. So CATCH is the word. And we've included Columbia University, Brigham and Women's, and University of Miami to look at, particularly if you look at access to lung transplantation for highly sensitized patients, patients using ECMO, bridge to transplant, and transplant for ARDS. So, and obviously that was highlighted by COVID. And our hypothesis was that the management strategies significantly impact the candidate's likelihood of receiving a lung transplant, as well as the post-lung transplant outcomes. And hopefully, by learning more about this, we'll be able to improve access to lung transplantation for patients with these historically understudied, but also historically known high-risk candidates. These are trials that just for interest, that are really ongoing only in Toronto right now. And what we're looking at is there's been experience in transplanting A2 kidneys to O kidney recipients. And, you know, a good 2/3 of our lung transplant waiting list are small stature O's, which tend to be women and tend to have a higher death rate on the waiting list. So can we use these A2 lungs that have low antigen expression in transplantation for these patients? And we've only enrolled one patient so far, so this still remains to be seen as to whether this will be as successful as it's been in kidney transplantation. This is another North Star trial run by Mark Dupereau in our group, non-ablative oligofractionated radiotherapy before surgical transplant as radiovaccination. And the theory was that if you give a sub-ablative radiation dose to a pulmonary malignancy, followed by resection of the radiated tumor with the explanted lung at the time of transplant, that you can get a radio vaccine, oncolytic vaccine function of this. And you know, we've basically they get an escalating low dose of radiation, and then they get transplanted. They get listed for transplant a week after they complete their radiation, and we're working our way through the dose escalation trial, and we've put about 14 patients into this trial as well. So again, these tend to be idiopathic, these are ILD patients, interstitial lung disease patients that develop these opacities that are new lung cancers. And often they get delisted for transplant once the diagnosis of cancer is made. So I think this is a very important trial. In looking at donor lung utilization, there are a number of trials. You know, we've done 1,200 EVLPs, as Marcelo and John, that brought this technology forward. And on the right, there is our thorax device. And, you know, we and others have published how ex vivo lung perfusion has certainly increased the number of transplants done around the world. And what we're trying to do is look at ways to improve the outcome. So again, this is using ex vivo lung perfusion, using lungs no one would use. You can get the equivalent results. But we realized that people weren't getting as good results as we were, and high utilization. And for example, we use about 65 to 70% of lungs put on the device go to transplant, whereas in the reported studies, only 20 to 30% of lungs put on EVLP go to transplant. And we realized that one big part of this is the information coming off those lungs is quite a lot of information. And so we've developed machine learning AI algorithms to tell the surgeon that that's a good lung or not. So we call that machine learning algorithm InsightX. And we're running a randomized trial where the surgeon is either given the EVLP report or given this InsightX report for decision support, which tells you green, the lung is excellent, use it, the patient will be extubated in less than 72 hours. Red, it's unsuitable for transplant. And yellow, it's a usable lung, but it has some issues and, watch out. But the really important thing also is it gives you on the right-hand side there, you see the top 5 parameters that the computer used to make that determination. And this trial is still ongoing, but what we really have shown is that it does help the surgeons make a decision. And what we're seeing is that with the InsightX report, the surgeons are more likely to transplant a good lung and more likely to not transplant a bad lung. So improving the precision in decision-making of lung utilization in transplant. Primary graft dysfunction prevention or treatment is a very exciting area. We've all been studying this for decades, but really, can we prevent it? Can we use what we've learned about the biology of lungs to actually prevent primary graft dysfunction? One of the things that falls under this category is how you do the transplant, protecting the lung or not within during the implantation. And the VIP-BOLT trial is the veno-arterial ECMO versus off-pump bilateral lung transplantation run by Mauricio and Zahar at the Mayo Clinic. And really their hypothesis is that off-pump lung transplant results in less PGD than VA ECMO lung transplant and a better 90-day survival. And their inclusion criteria is bilateral lung transplants, mean pulmonary artery pressure of less than 35, and eligible for off-pump VA ECMO based on judgment of the attending surgeon. So as you can see, it's sort of the lower risk transplants, should you try and do it off-pump or not. Primary endpoints, PGD at 72 hours, mortality at 90 days or during the hospitalization, or a combination of those things. They plan to recruit 228 patients. They recruit 100 to date, and they have some interim analysis. So we'll all be interested to see that as, again, people's practice is changing in terms of how many transplants you perform on ECMO versus off-pump. A very, very exciting trial, really led by Joran Madsen, and us is All in Lung, which is a CTOT NIH trial. But this is all on hold thanks to our friend, Mr. Trump, targeting inflammation and alloimmunity in lung transplantation. So basically, this is a drug using anti-IL-6 receptor antagonist, tocilizumab, given to the patient prior to implantation to see if this will prevent primary graft dysfunction. Now, IL-6 is a key cytokine that inflammatory cytokine that we see is produced by many cells in the lung and is usually high in lungs that we would see have a problem early out of the starting gate. So the endpoints are development of CLAD and listing for retransplantation or death. And I think that that's really important in terms of looking at how does the early injury lead to the chronic lung allograft dysfunction or death in lung transplantation. And finally, cell-free DNA in lung transplantation can reflect the overall injury burden to the lung or rejection. I mean, basically, when a lung is injured, when any cells are injured, we all have little bits of cell-free DNA floating around. And the concept here is that the floating cell-free DNA is from the donor lung. And there are a number of centers that are participating in this Alamo trial, which is looking at cell-free DNA with the primary endpoint of evaluating the diagnostic performance characteristics of cell-free DNA in early lung allograft dysfunction and chronic lung allograft dysfunction. And again, this is still an ongoing trial, but it's very interesting when you look at the kind of data you get. Clearly, there's a peak of cell-free DNA circulating at the time of reperfusion that comes down to a quiescent level at around 5 or 6 months after the transplant. And then some patients it goes up and some it doesn't. So I think the early part reflects the injury, the later part reflects the immune injury coming in. And again, in lung transplantation, we're going to be faced with the same problem, that infection and rejection can both injure the donor lung. So I'm not sure it's going to differentiate those, but clearly I think if your cell-free DNA is down and your lung function is good, you're probably okay and probably don't need a biopsy. So, you know, I think this will stratify patients for which ones you need to bring. Don't try and read this, but the ones you need to bring to the hospital to have their biopsies and evaluation versus ones that can just continue living their life at home. There are a number of trials going on in CLAD prevention or treatment, and one of them we're looking at, again, Megan and I are the Toronto site PIs for this, but really the PROMISE study is a multi-center study to look at, it's an NIH study led by Scott and Jason to look at management strategies to improve lung outcomes over time. And we're just going to meet to talk about, well, what are the things that we can do that will really impact on the long-term outcome of patients after transplant. We've added blood collection to the what we're going to do in these patients, and hopefully this will give us some insights of where to look in these patients. Now, Teresa Martin, who helped me with a few of these trials, I mean, there's a lot going on in CLAD. I think a lot of this is shooting in the dark, and really we've got to intervene earlier, but some of the recently completed trials to keep an eye out for the results is inhaled cyclosporin revisited again in terms of the efficacy and safety of liposome-delivered cyclosporin to the lung. And then pirfenidone for pulmonary fibrosis and CLAD fibrosis, you know, particularly interesting for single lung transplant recipients, and nintedanib, the same thing, being investigated but not yet published. And then some of the trials that we're doing here, and is the Bellamy-Sodale trial as well. And then there's you know, international Alberto and in the Vienna group has been very keen on this, looking at extracorporeal photopheresis for the treatment of CLAD, and also the prevention of bronchiolitis obliterans using nebulized agents. Again, they haven't told us what the agent is in that trial, but some very interesting areas on patients who have already been transplanted and have lung allograft dysfunction. So I'll be happy to take any questions from here.
Yeah, thank you, Shaf, for this great overview on the plethora of trials going on in the lung transplant field. So for the audience, please ask your questions in the Q&A tool or in the chat function. One question for all of you, in clinical trials where the actual surgical component is randomized, is frequently difficulties with randomizing patients or with patients volunteering to participate have been encountered. Can you tell us a bit about what your strategies would be to ameliorate this, or what you could do in advance in communicating trials to avoid this? Maybe Isabelle.
Yeah, I can start. Thank you. I think that's a very relevant question. I mean, that's very often the phenomenon that's called clinical equipoise, that maybe the intervention is perceived or actually already shown in other settings to be better than the non-intervention group. And I think this is an effect that has to be carefully assessed before you start any trial, right? And once you really are in the situation where there is no evidence if the intervention or non-intervention is better, what is a good advice, I think, is to perform interdisciplinary consulting with the patient in the screening phase. So this means, let's say, for example, the Sincere trial or the Salvage trial, where I can speak out of experience. When a patient is eligible from all inclusion criteria, it is to be recommended that the patient is seen in an outpatient setting by experts from both treatment arms, where it can be in an unbiased fashion explained to the patient what is the advantage or disadvantage or unclear evidence in the particular situation. That's my recommendation.
For me, I would say that I've got experience in 3 trials, raised over 6 million in multi-center trials in the UK. And it boils down to one thing. Are your friends want to help you, or they're not going to help you? That's kind of what it boils down to. And Isabelle gave it like a real textbook answer. But at the end of the day, equipoise, schmequipoise, right? Because if they're going to help you, they will help you. And if they won't, they won't. So in the UK, what we did was we allocated about 300,000 for each trial to train surgeons how to speak to patients, to make sure that they can randomize the patients. And so for Violet, it was very successful. We audio recorded the conversations that the surgeons spoke to their patients, and we gave them feedback about how they spoke to the patients. If they say things like, would you like the standard operation, or words to that effect, we corrected to say that this is what we do and here's what the alternative is, so that the language is important to the patients. And so as we train the surgeons better, more patients signed up to the trials.
And I would just add that another part of it is like you said, not so textbook. It's about threat to your business and livelihood, and in North America, it was very hard to get patients for surgeons to randomize patients to a trial like stablemates, where they may get radiation and not get surgery, and those early stage lung cancers are the patients that are most likely cured by surgery and have had historically good results and are easier to do. And so, like you said, are your friends going to help you or not? I mean, at the end of the day, you want to know what's best for patients, and if it really proves out that SBRT applied to a patient gives them equivalent cure rates and long-term survival and quality of life, then surgery, maybe you would avoid an operation and side effects. I do think that you should be looking at the side effects of radiation very carefully, because people assume that if it's non-surgery, there's no side effects. So and you've seen the people who've had radiation for laryngeal cancer, for example. I mean, their teeth have rotted out, their jaws have rotted out, they've got all kinds of problems with dry mouth and horrible quality of life, and they can't eat and can't swallow. Sometimes they get esophageal strictures. So, that needs to be balanced with surgery.
Can I add something, Clemens? I think it's also very important that we have now a platform for surgeons. Many trial platforms are run by oncologists. And I think if we now have a platform where surgeons come together and where the primary goal is really to support surgeon-led trials with accrual improvement, education, and quality of conducting the trial, I'm pretty optimistic that this will also help to increase surgical activity in such trials.
And I think it's also very important, as Isabelle said, like if it's a fair trial, like we want the best for patients. But when you see some of the trials that are run by groups with different ulterior motives, like you'll see in some of the cardiology trials and cardiac surgery, there's a huge battle going on, and part of it's just because everybody isn't at the table when these trials are being designed. So creating a venue for surgeons to be at the table, I think, is particularly important, and creating a venue where people who are knowledgeable about proper trial design will ultimately get us the right answer. So, kudos to you guys for setting this up.
I think collaboration with industry is obviously an important factor also in clinical trials. And probably we as surgeons have not embraced that in a way like internal medicine colleagues did, or other specialties. What's your take on this? How important do you consider collaboration with industry in trials?
I mean, I can start, but I think Shaf is really a very good person to speak about this. I think it's absolutely necessary and indispensable to be in exchange with industry to know what is on their horizon, their areas of interest, and on the pipeline of any compounds or medtech devices. It's really important to be in exchange with them and to collaboratively design and execute clinical trials. It's always, of course, a small line or to have, let's say, too many disclosures which come into the gray area of conflict of interest. But I think as long as everything is transparent and open to public, this information, this should be okay. But I'm happy to hand the word over to Shaf.
Yeah, no, I mean, I think that's a really important area, but not only so much understand what they have in their pipeline, but they have to understand what our interests are and where we're going. And so I think in a lot of areas, that's where we can guide them. But as you saw, I mean, many of the things we've done, we couldn't have done without CSL Behring and Abbott and United Therapeutics and so on. Like these companies, they have the resources to help us achieve these big trials and answer these important questions. And as Isabelle said, it's a fine line because, yeah, of course they have their own interests, and that's where we have to be strong and say we're the drivers here. And then when we do a trial with industry partners, they don't get to write the paper, they don't get to analyze the data. And that's something you have to set up front, and they have to be comfortable with that. So if you're a leading institution and they come forward and they say, well, we want to look if XYZ is better for lung cancer, well, then we say, okay, this is the trial, this is it, and this is what we're going to write. And we give them 30 days to look at it, but not to change it, and so on. So, I mean, I think these are very important things, but I think it's critical to involve them, and it's going to be the way forward in funding trials. I don't know how, Isabelle, how you're funding these trials here, but I think one of the models in TSOG is good. I mean, there are the classic, like, AstraZeneca funds their trials, but there's also funding for the TSOG initiative, from industry. So it's not for a particular trial. That's kind of exciting too.
Eric, anything to add from your perspective?
No, I think it's critically important for surgeons to be involved in the trial design, and I think Isabelle, myself, and a few others are helping AstraZeneca in designing troponin lung 12. This is an example, where they wanted to recruit stage 1A, but didn't understand that wedge resections are going to be used more commonly. We introduced this concept to them, so we managed to actually influence the trial design. I think in today's day and age with the pharma trials, there's too much at stake. the surgeon won't have a say in the much more than the surgical sections. The trials are running in the hundreds of millions, and with that, they are carefully, extremely carefully designed to ensure that no stone is unturned, that there is a pure answer, preferably in favor, and make sure there's no dilution of the effect of their new compound.
Okay, so we've already come to the end of this webinar. So I would really like to thank the three of you for taking the time and for providing us an excellent overview of what's going on in the respective fields. I'd like to thank the audience for participating, and I'd like to point out our next webinar in December 15th, which will be on the topic of esophageal cancer, and Lieven de Pieper from Leuven will be the presenter. Thanks again for today, and looking forward to see you again there.
Thank you.
Bye-bye.
It was an exciting program. Thank you.
Bye.